First of all, I would like to thank Dr. Judith Trotman for organizing this event, and I'm very happy to be here with you, and Celgene for sponsoring my trip to Australia. I was asked to provide an overview regarding the current status of patients' outcome for both myeloma and Waldenstrom's. And as you all know, these are diseases. Myeloma is a quite common disease. It's the second most common hematologic malignancy. Waldenstrom, it's much less common. We believe that there is one Waldenstrom patient for every 5 patients with myeloma. However, there has been significant improvement in the treatments for both diseases, as you know, and as we will see later. And thus, it is not unrealistic for both physicians and patients to start thinking about the concept of cure. And as a patient with myeloma several years ago indicated, cure is to live a long life and die of something else. We have to keep in mind that today many patients with myeloma may have a long life. There are many patients that have remissions which exceed 5, 7, or even 10 years, and still there are some patients with myeloma, detectable myeloma, that die of an unrelated condition. First of all, we all know today that patients are being diagnosed frequently at an asymptomatic stage, what we call smoldering or asymptomatic myeloma. And it is clear that these patients should not be treated right away because we don't have any proof that by initiating treatment early on, this will change the outcome of the patients. There are certain criteria that physicians dealing with myeloma apply when we recommend treatment, and it is likely that these criteria will be revised in order to avoid delaying treatment so that the patient does not have a complication. And also it is important to note that many patients with asymptomatic myeloma may remain without progression for many years. This is what we call a reverse Kaplan-Meier curve, and as you can see here, the yellow line shows the probability to develop progressive disease, meaning symptomatic myeloma or amyloidosis, in patients who have a much more common condition, which is called monoclonal gammopathy of undetermined significance. And you can see that these individuals, because we should not call these individuals patients, they have a low probability, which is about 1 to 2% per year. The blue line shows what happens to patients with asymptomatic or smoldering myeloma. And as you can see here, for the first 5 years, the chance to need treatment is approximately 10% per year. However, with further follow-up, this probability is reduced to 3 to 5% per year, and subsequently, after 10 years, the curve looks like the MGAS curve, is about 1% per year. This indicates that this is a heterogeneous population which comprises subsets of patients. The take-home message here is that there are many patients with asymptomatic myeloma that may not need treatment for many years, and right now there is active clinical research to try to identify the subset of patients who are at a high risk for early progression and to decide to treat these patients preemptively to avoid complications. I'm sure that all of you have seen this graph, which indicates that for many years we did not have many drugs for the treatment of myeloma. I have been very privileged to work with Dr. Alexenian, who actually was the person who in 1969 described the melphalan-prednisone combination, which is being used as part of myeloma treatment even today. For many years, the only progress was the administration of high-dose dexamethasone, either alone or with vincristine and doxorubicin, and also the administration of high-dose therapy and autologous stem cell transplantation, pioneered by McElwin, by Dr. Barloghy, by Dr. Alexenian in the late 1980s, which gave a survival advantage to a proportion of young patients who were receiving this treatment. However, it was only after 2000 when we have a real explosion in the medications and the regimens that are available to myeloma patients. Already we have 3 not so novel agents anymore, lenalidomide, thalidomide, and bortezomib, which have been approved for the salvage setting, for the frontline setting, and very recently, this year, we have the approval of 2 more novel agents, pomalidomide and calfizomib, and we are very excited because for the first time also we have effective monoclonal antibodies such as elotuzumab and especially daratumumab. With the new combinations based on these novel agents, there is a continuous improvement of the response rate of the patients who receive what we call induction therapy, as you can see here. Not only the overall response rate is improved, but also the complete response rate is improved. And I will share with you data which indicate that clearly the survival of myeloma patients is steadily improving. These are data from Little Rock, from Dr. Barloghy Center, where for the last 20 or so years he is advocating a very intensive approach of treating myeloma patients. These data apply for selected myeloma patients, but nevertheless, you can really appreciate that there is a continuous improvement of the overall survival of the patients diagnosed many years ago, and today we can anticipate that at least for patients treated with this approach, approximately 20% of patients will be event-free in complete response for more than 10 years, and likely several of these patients will be cured. We know that the survival of myeloma patients has improved considerably with the availability of novel agents. So if we compare the outcome of patients treated below 2000 with those treated after 2000, we can see a significant difference. But recently, the Mayo Clinic group indicated that even within this decade, there is a continuous improvement of the survival of the patients, and it is very rewarding to see that this improvement is also seen in older patients with myeloma. Thus, we are continuing to improve the survival of myeloma patients every year that goes by. These are data from the Greek myeloma study group, and as you can see, there is a continuous improvement over the last 10 years, and even for patients who receive high-dose therapy, these are data from our center. Patients who were receiving high-dose therapy before year 2000, median survival of 4 years, now it's approaching 9 years, indicating that the use of novel agents as induction, consolidation, in some patients maintenance, and effective treatments at the time of relapse is causing a continuous improvement in the survival of the patient. Very recently, a few days ago, Dr. Anna Kalf presented an update of the Australian thalidomide maintenance trial, which indicates that with a very long follow-up, there is a continuous improvement on the progression-free survival and the overall survival of patients receiving thalidomide and prednisone after high-dose therapy, and these data are important to the treatment decisions that we make after high-dose therapy. Maintenance therapy is an important component in the treatment of myeloma, and we have data with lenalidomide, the second generation immunomodulatory agent from France, and from the United States. And you can see that in both of these trials there is a significant improvement in the time to progression in favor of lenalidomide maintenance after high-dose therapy. And in one of the trials, in the American trial, there is also a survival advantage. And we are very much interested to see a longer follow-up of these trials to see whether we will have a definite survival advantage with lenalidomide maintenance therapy. Thus, because oftentimes physicians and patients wonder what is the role of maintenance in myeloma patients, it is clear that maintenance is prolonging the time that the patient will remain in remission. In several studies, also there is an advantage for the overall survival of the patient, and we need some more follow-up to fully assess the impact of lenalidomide. So many patients with myeloma today live a long and healthy life, but they may never achieve a complete response. So this may not be a negative sign, because we know that in some patients there is a residual monoclonal protein detected, and we believe that some of these patients may have reverted to the MGUS stage that we know that usually precedes myeloma. And today we have a lot of drugs that can be given to patients at the time of relapse. However, physicians and patients should not be always very anxious to start immediately treatment when there is evidence of rise of monoclonal protein in the blood or the urine without any symptoms, signs, or laboratory abnormalities. This is something that we call biochemical relapse, and we know that in some patients this may persist for several months or even years without the need to administer therapy. And it depends on the expertise of the physician and the patience of the patient to decide what is the best time to initiate another line of therapy. In order for myeloma patients to have a good quality of life, it is important to manage also the complications of the disease: anemia, neutropenia, bone disease, renal impairment, and also to prevent or to treat the complications that sometimes occur with therapy: neuropathy, fatigue, immunosuppression, osteonecrosis of the jaw. And we know that we have erythropoietin today, or erythropoiesis stimulating factors, to keep the hemoglobin of the patient between 10 and 12. We know today that we don't want patients to have a very high hemoglobin. We have GCSF to prevent or to treat neutropenia and reduce the severity and the probability of infections. And also we know that good hydration, prompt initiation of treatment may prevent renal failure. However, there are patients on long-term hemodialysis that may survive for many years and they have a good quality of life. And also biphosphonates and newer bone treating agents are in development to prevent or to treat bone disease, along with procedures such as vertebroplasty and kyphoplasty, who are helpful in several patients with specific problems. Now I would like to switch to Waldenstrom's, which is much less common than myeloma. It has a longer survival than myeloma. It is considered a more indolent disease. It resembles more a low-grade lymphoma than myeloma as far as its prognosis is concerned. And again, in Waldenstrom's, we have many patients who do not need treatment. They have asymptomatic disease, and these are data from SWOG and from Mayo Clinic to show the pattern of progression to symptomatic disease. There are several available options for treatment of Waldenstrom's. In this disease, Oftentimes, we want to be more gentle because we know that even with minor reductions of monoclonal protein, you have enough reduction of tumor load that will alleviate the patient's symptoms. And in this disease, also we have many new therapies. In the 80s and 90s, we had only alkylating agents, nucleoside analogs, but today we have a very effective monoclonal antibody, rituximab, which is considered the backbone of therapy. And the last few years, we have new and exciting drugs, and as we speak, a very interesting drug, ibrutinib, which is likely to get approval by the FDA, the first drug ever approved by a health authority for Waldenstrom's. Which one is the best treatment is difficult to tell in patients with Waldenstrom's. There are many effective therapies. This is a relatively mild regimen consisting of rituximab with oral cyclophosphamide and dexamethasone, which can give you a quite long median time to progression of 3 years with a long overall survival of about 8 years. And again, asymptomatic increases of IgM do not necessitate therapy, and several of these patients can be followed for many months without the need of therapy. After relapse from primary therapy, again, there are many possibilities and many options for the patients, and they keep increasing. And it is important to note that especially in Waldenstrom's, there are many patients, several patients that die of unrelated causes. And this is an analysis that we will present at ASH this year based on 400 patients that we have collected in our Greek myeloma study group. And you can see here that 1 in 4 patients with Waldenstrom will die from an unrelated cause, this being another cancer or heart condition or other conditions. Thus, it is important to keep this in mind when we analyze studies with Waldenstrom macroglobulinemia. For Waldenstrom's, we have data, again, from Sweden to indicate that the overall survival is improving. And as you can see here, in some patients, it can reach the normal life expectancy according to the age of the patient. Thus, the improvement of the outcomes of patients with myeloma and Waldenstrom is continuous. A complete response is desirable, especially in myeloma, but for several patients, lack of complete response does not indicate treatment failure, and patients should not be discouraged as long as there is no evidence of progressive disease. And today, in many younger patients, we can increase the depth of response by applying high-dose therapy, consolidation, maintenance. And also, there are more and more agents available to physicians and to patients to treat patients at relapse. And we know that when an agent is effective in the relapse refractory setting, then there are studies that will eventually move this agent to earlier phases of the disease. And we envision a treatment that will include different agents with a different mechanism of action, a proteasome inhibitor, a monoclonal antibody, an immunomodulatory agent, steroids, and maybe also one of the standard chemotherapeutic agents. Thus, to conclude, there are data, firm data, to indicate that the survival of both myeloma patients and Waldenstrom is improving. And as we speak today, we believe that a fraction of patients with standard risk myeloma are being cured, and we hope that this proportion of patients will increase over time. Thank you very much.